And now we go with the second speaker, which is Oriol Roca from Parc Taulí University Hospital from Barcelona. Oriol.
Thank you, Marcelo. Welcome, everyone. I would talk a little bit about how we could optimize oxygen delivery in patients under high flow. These are my conflicts of interest. The part of the results that I will present were partially funded by Hamilton. Well, the current guidelines recommend that adjusting flow rates to keep SpO2 in the target range that you have already decided when you are going to treat the patient. But careful selection of FiO2 values to keep SpO2 in the recommended target range while preventing the risk of hypoxemia that we are all aware, but also hyperoxemia. If you keep a mice for 4 or 5 days breathing 100% of oxygen, the mice will die. So this is a well-known and described experimental model of lung injury. And maybe when we are in the ICU and we see a patient who is saturating 100%, we do not react as fast as when a patient is saturating 88%. However, the careful selection of FiO2 requires frequent manual adjustments of the FiO2, which is a process that is time-consuming and it is not always feasible, especially in this era of limited staff resources that we have recently seen during COVID pandemic. What we know about this automatic oxygen control in different settings? This is one of the first studies, but included patients treated with low-flow oxygen, and as you can see, the time that the patient was in the desired SpO2 target range was higher when the patients were treated with an automatic system compared to the manual titration. We have more data in high-flow patients. These are COPD patients that were performed a 6-minute walking test, and the time that they spent in the target range when they were on high flow, which an automatic oxygen control, was 26% higher compared to when they were not using this automatic oxygen control. Finally, it has been also tested in a very short cohort of mild acute hypoxemic respiratory failure. I said mild because, as you can see, the FiO2 that they were using was 0.3, which is very, very, very low. In any case, again, the time that they spent in the target range was significantly higher compared to the manual FiO2 titration. So in this scenario, we designed the HILOOP study that was a multi-center randomized crossover trial comparing manual versus closed-loop oxygen control. Each strategy was assessed for 4 hours, and we include all adult patients that were admitted in the ICU who require high flow and need an FiO2 equal or higher of 0.3. Of course, we had a lot of different exclusion criteria, mainly the ones we exclude patients that need that present immediate criteria for intubation or that were deemed at high risk for need of mechanical ventilation within the next 8 hours, which was the period of the study, and so on. And we estimate that, according to the first study that I present, we estimate that we would need 45 patients, and because we know that we would lose some patients during the study because of problems of recording, or maybe some of them would have been intubated during the period of the study, we increased the sample size up to 50. This is the schema. It's very easy. We only randomize the period the system that we delivered in each period, and we left 15 minutes washout period between these 2 hours period. We decide the clinician in charge, because there is a lot of controversies about the optimal SpO2 target range in ICU patients, regardless the type of support that they are receiving. So we were pragmatic in this point, and we decided that the physician in charge, the one who choose which range of optimal target SpO2 was the better one for the patient that he was in front of. And according to that, above these limits, we have a suboptimal range that we consider that was high or low, and above or below this suboptimal range, we call the out of range thresholds that were unacceptable, let's say. As we said, we randomized 45 patients. These are the baseline characteristics of these patients. Mainly, we did it during the second wave of COVID pandemic, so mainly 80% of the patients were COVID-19, and mainly they were admitted to the ICU due to the novel acute hypoxemic respiratory failure. And I want to take your attention on the initial FiO2 that the patients received was 0.5, and they received almost 50 liters per minute, which is completely different to the previous study that I have shown before. These are the baseline characteristics at the beginning of each period that were well balanced in terms of hemodynamics and respiratory support. And this is the result of the primary outcome. Again, the time that the patients spent within the optimal SpO2 range during automatic oxygen control was higher compared to the manual titration. But not only the time that they spent on the optimal SpO2 zone, which is represented in this green color, but also they spend less time in the suboptimal range and even less out of range height. And this makes a lot of sense, because if you are in the ICU and you see a patient that is saturating 88%, you rapidly go inside the room and increase FiO2. But if the patient is saturating 99% and you have a lot of things to do, maybe you start doing these things and not go to the patient and decrease FiO2 to keep the patient on the target range that you have previously decided. So the manual adjustments per hour that you need to do to the FiO2 was obviously higher in the manual group. In fact, no manual adjustment was required in the automatic arm, automatic oxygen control. Our nurses were extremely happy with this system because they didn't have to go inside the room just to decrease or increase FiO2. And what about the percentage of time that the patient spent in different FiO2 levels? The first thing that you can see here is that the amount of time that the patient spent with an FiO2 below 0.4, it's much higher in the automatic oxygen control compared to the manual titration, which means that maybe these patients could be more rapidly weaned from high flow. Because imagine the situation that you go to the ICU, you start treating the patient, and you leave at 5, maybe, p.m., and the patient is 50 liters per minute, 0.5. And your colleagues that are on duty in the hospital had a lot of work, so they could not attend to the patient. The patient is doing well, but nobody moves or decrease the FiO2. And you arrive the following day at 8 o'clock in the morning, and you see the patient saturating at 98, 99% maybe with an FiO2 of 0.5. So you have to spend the morning decreasing FiO2. In the situation that automatic oxygen control is working, this happens during the night. So when you arrive at 8 a.m. in the morning, the patient maybe already is with an FiO2 of 0.35. So you can then start decreasing the flow and weaning the high flow device from the patient. So we are maybe winning time in this sense. By contrast, there is another important thing. If the patient deteriorates, the system will increase FiO2. And you need to be aware that the patient is deteriorating because you will not have the alarm of SpO2. The SpO2 will keep in the target range, but the FiO2 will go up. And you need to be aware, the device need to advise you that the FiO2 has been increasing by 20% or above 0.6 or whatever to make you take a decision on what's going on with the patient if you have to escalate the treatment or change it. Another thing that is very nice to see is that the system works, the performance of the system is pretty constant regardless the level of oxygenation impairment that the patient has. On the left side, you have how the time in the optimal range of automatic oxygen control at different levels of FiO2, and this is the manual group, the amount of time in the within the SpO2 desired target range. And as you can see, the higher is the severity, the worse work the manual titration of oxygen. You can do it with the initial FiO2 or the initial ROX index, and the curves are exactly the same. And what about another thing that maybe we are not so concerned, but it's also important, especially during the COVID-19 pandemic, where oxygen, we have a lot of scarcity of oxygen, which is oxygen consumption. We did not find any difference overall difference in terms of oxygen consumption, but remember that we only assess a 4-hour period. When we assess the period that the patient spent above the optimal limit, so at that time we are wasting oxygen, we are wasting more oxygen during manual titration compared with closed-loop oxygen titration. So we could potentially save oxygen by using automatic oxygen control. Not only is important for the patient, but also at hospital level for the managers. And we perform different sensitivity analyses according to the severity of the patient, according to the etiology of acute hypoxemic respiratory failure, and according to the target range that the physician in charge decided to use. And the results were pretty consistent regardless the oxygenation impairment, etiology of acute respiratory failure, or the level of SpO2 target desired. I will show you an individual example. This is manual titration. And in white, do you have the desired range. In orange, do you have the suboptimal range, and in red, do you have the out of range SpO2. And the black line is the SpO2, and the green line is the FiO2. This is during manual titration. Here, the nurse or the physician, because the patient was above the limit, decided to decrease a little bit FiO2, but following this period, the FiO2 remained constant, which at the end results that the patient only was in the optimal range around 50% of the time that we record. By contrast, when you use automatic oxygen control, every time that there is a drop in the SpO2, it is immediately followed by an increase in FiO2, which means that the patient remains much more time within the optimal range compared to the manual titration. And I was very happy because last week appeared this paper that was a review published in ISICEM that analyzed trials on oxygen targets in critically ill patients who were mechanically ventilated. We are now currently testing what we have seen in high flow in mechanically ventilated patients. I hope that I will be able to present soon the results. But look at these 3 trials that compare different strategies of oxygen targets. All have the same problem. They design the groups, but then when they put it in practice, there were no difference in the groups according to the SpO2 that they finally achieve at the bedside. And this is because they do it manually, and we are not 24 hours per 7 days at the bedside titrating FiO2 to keep the SpO2 on the target range. So I think that if you want, and they also talk about the MegaRocks trial that is trying to include 40,000 patients, if I'm not wrong, and they say that they have the same concerns that they observed in these 3 trials, because it is very unlikely that they could achieve a good separation between groups to find difference in outcomes as they want. So closed-loop oxygen control improves oxygen administration in patients with moderate to severe acute respiratory failure treated with high flow. It increased the percentage of time in the optimal oxygenation, and it decreased the workload of the personnel, of the healthcare personnel. The effects on oxygen consumption and the duration of high flow should be analyzed in further studies with larger sample size and prolonged periods of time of use. And these results were especially relevant in a context of limited oxygen supply and high medical demand, such as the COVID pandemic that we recently have to face with. Thank you very much.
Oriol. So it looks like from your presentation that you can adjust in the ventilator the range you want, right? So if I want to keep higher, I can set this. Do you know more or less how often the system corrects? Because I could see still some drops even in when you are activating the system. So which is the response time for correcting FiO2? Do you have any idea?
Yeah, I think that it depends. It's much faster when there is a drop than where is an increase.
Okay, makes sense.
Which makes sense because it's more dangerous the drop than the increase in SpO2. If I'm not wrong, and I'm talking in memory, I think that in less than 30 seconds the system increase, but the increase is progressively. So if you are at 50% of FiO2, you don't go directly to 100% unless you are out of range. So there is an escalation of increasing FiO2 according to the drop that you have in SpO2.
Oh, this is why we saw some overshoots. I see. Okay. Oh, okay. But anyway, I like it very much, the concept that you can even have some economy of oxygen. And certainly the amount of adjustment, the difference in the amount of adjustments was remarkable. Huh? So I like it very much.
And if we compare the amount of oxygen that we are using during high flow compared with mechanical ventilation, it's extremely higher because we are delivering 60 liters per minute during all respiratory cycles.
Yeah.
And in mechanical ventilation, during expiration, there is no more oxygen.
And I think the most, let's say, important, I think you made a good point. I think the most striking conclusion from this very small study, but I like physiological studies, because all these trials, big trials with thousands of patients of which the target saturation, they don't have any meaning in clinical practice because they didn't achieve the goals. Thank you very much for this.